Thank you. Perfect. So before I'm going to start this presentation, maybe you all are wondering, who is this weird young lad who's filming himself? As Noreen has just said, I, on the side, run a little YouTube channel where I run it with the goal of making HUR and market access more accessible to the public, to lay audiences, because one thing that's very dear and close to my heart is that we all work in this industry where we work with so much technicality, and yet so much of that detail is lost, and a lot of the public is not really aware of what we do as the pharma industry. And there's this very bad negative reputation that the pharma industry has. So my goal is really to change that, because I strongly think that if you were to ask 100 random people out there on the streets about the most evil industries they could think of, the most 3 evil industries, I'm sure they would say the military complex, they say tobacco, and they say pharma. And two out of those 3 industries kill people, and one of those industries saves life. So I just want to save that. I want to change that perception, and that's what I'm trying to achieve with my YouTube channel. But I also do have a real job. After all, I do need something to pay the bills. So I also work for Gilead Science in the market access team for the UK and Ireland affiliate, which is also why I've got this legal disclaimer here that all the views and opinions expressed are solely my own and do not necessarily reflect the ideas and opinions of the company that I work for. So with that out of the way, what are we going to do for the next 40 or so minutes? I really want to do 3 main things. The first thing is I want to look at the US and just have a look at the US as a system where market access is being done quite differently than it is in Europe, as sort of like a high price environment where a lot of the revenue for the pharmaceutical industry is coming from. And then as a second step, I sort of want to contrast that with the UK as one of the examples of a European market that is quite heavily influenced and driven by cost effectiveness, sort of putting that into the stark contrast with the US on the one side, and then the UK on the other side, heavily focused on cost effectiveness. And then as a third and last step, what I want to achieve with this session is I want to look at solutions. So what are the things that we can do? What are the things that we can potentially improve on? And what are some of the ideas to make market access more approachable? Really with the overarching theme of, are we getting fair value in Europe, or are we really just all living in a false economy? So starting things out. Looking at the US, I'm sure you're all aware of this figure. More than 50% of global drug revenue is generated in the US. More than 50%. I think that is such a stunning number to begin with. So when I first saw that figure, I couldn't really quite believe it. So I tried to contextualize it for myself and put it into a better framing so that I could understand, is it really justified? Why is that the case? So the first thing I tried to do was just to put it into perspective. Okay, maybe there's just a lot of people living in the US. I think it's about 340 million or so odd people. Does that account for it? Well, not quite. So if you put that, the total number of people living in the US as a share of the global population, around 8 billion or so, you end up with just over 4%. You put that in contrast to the 53.2% of the total US prescription drug market share. Doesn't quite account for the fact that so much of the market is driven by the US. So then I was thinking, okay, maybe the US is a great economy, has a strong GDP. Maybe if we're starting to adjust for GDP, that would somehow explain why there's so much money coming from the US for the pharmaceutical industry. So that's where I was looking at next. So here we've got total US GDP as a percentage of the global GDP. Again, you see, we're getting closer. We're getting closer with just over 1/4 US GDP as a percentage of total GDP. But again, still not accounting for the more than half of the total market share of the global drug market as a whole. So that then left me wondering, with all the current changes that are being proposed, we've heard from Reg before about MFN already. There's certainly, it feels like we are in an environment where things are about to change. I was asking myself the question, what happens if we cannot rely on the US anymore? What if this world where all of the money is coming from the US, what happens if that goes away? Can Europe survive by its own? So that's the question. What if pharma can't rely on the US anymore? And I tried to answer this question for myself by just taking two perspectives. First, I wanted to be an optimist and take like a positive attitude on things. And then I also wanted to take the cup half empty sort of perspective and look about a pessimist answer to this question. Starting out maybe with the optimist answer to this question, what happens if the US goes away? Maybe this would lead to more global cost sharing. Maybe that's the opportunities where other countries really step up their game, come in to fund global innovation if we know that we can't rely on the US anymore. Maybe there's also efficiency gains. Maybe if there's not that much more money flowing around in the US, maybe that would eventually lead to pharma companies tightening their belts and doing restructuring, becoming more efficient, maybe letting some people go as well. But essentially becoming leaner and more effective, more targeted research and development efforts. Maybe there would also be a shift for a pricing reform, a more push for value-based access regimes and more subscription-based models and more innovative access equity methods for basically, again, just going to that point above where other countries are stepping up to fund the global innovation of new pharmaceutical products. So then if we sort of take the other perspective, the pessimist view, what would happen? Well, we could think about an innovation slowdown, fewer new breakthrough therapies, especially for rare diseases where huge initial investment is needed. If that's not coming from the US, who's going to pay for it? Second, a biotech contraction, so loss of jobs, reduced US leadership and in the life science industry, and generally a global access gap, so lower US investment that could delay access to new medicines in poorer countries as well. And then lastly, a fragmentation of innovation. So without the US leadership, again, maybe we see not as much drug development anymore, and everything becomes sort of disjointed and less efficient globally. So those are the two perspectives you can take on it. And I think a lot of this just relies on this very, very fundamental idea. And I appreciate it's quite an obvious thought, but I'm not sure a lot of the time people do follow this ideology, which is something that I believe in. Because if you've got a bigger market, I would stipulate that there should be more innovation, right? If you've got a smaller market, you've got smaller innovation. That's just the thought. I think it's something that should be quite obvious, but I'm not sure people generally do understand that when they talk about, reducing the size and the profitability of the US market. Do they really follow this simple logic? I'm not sure. So following on from that idea that the market size sort of drives value, drives innovation, I was then thinking, what actually impacts health spending? What is the pattern? What do we see globally? And there's this great website called Our World in Data. And I took this chart from it, which basically plots GDP per capita against the current health expenditure per capita. And it does that across a broad range of countries that are depicted here. So what you can see is basically that the richer a country becomes, the higher its GDP per capita, the higher its current health expenditure is. You see, you can pretty much draw a straight line across all of these countries here. So you've got countries like the US being at the very top, high GDP per capita, also very high current healthcare expenditure. Countries like Norway as well, Japan. And then at the lower end of that, you've got other countries, with a much lower GDP, Burundi, Mozambique, Liberia, Zambia, Sudan, So there's this clear trend. Okay, so we understand that. Then what happens next? Because the healthcare spending that's one thing, right? But we don't necessarily care about the amount of money we put into something. We want to know what are we getting for it, right? What's the outcome? So I think a chart that's more interesting to study is what does it actually mean, our healthcare expenditure per capita, how much life expectancy are we getting out of that? So this is what we see here. Healthcare expenditure per capita on the x-axis, and then on the y-axis we've got life expectancy. And can we see any trends? I would argue yes, we can. With most countries, you can still draw sort of a line across here. You see that the more healthcare expenditure per capita you have, the higher your life expectancy will become. So you've got, again, countries like France, Italy, Japan, relatively high healthcare expenditure, but high life expectancy as well. But we've got one outlier as well, which is the US. So really, that leads to the question, what's going on here? So much investment, but only relatively little life expectancy in contrast. So what's going on in the US? And this slide touches on something that, again, was sort of mentioned in Rex's talk earlier, which is, and I started this with just one very big number here, which is close to $50 billion US, and that is the amount of money that has been paid by Johnson & Johnson in rebates, discounts, and fees in only 1 year. So that is from one of their most recent reports. And they break it down. I'm only showing one of the categories here. But from that roughly $50 billion US, almost $15 billion is spent on private insurers and PBMs. And I've learned earlier today that apparently there's reform going on with the PBMs. That's something I wasn't aware of. So maybe that's something to be excited about, maybe some positive change. But yeah, that just shows there certainly are quite a lot of inefficiencies in the system that need to be addressed. And it is not to say that the US is a perfect system. It very much isn't. There are things that need to be changed. So this chart looks at pricing, and I think this was picked out by a Guardian article not that long ago with the exciting headline that the US pays almost 3 times as much for their drugs as other countries do. And I get it, it's a catchy headline, and they're right. If you actually look at the reference paper that they cite for that information, they present 3 sort of like grouped analysis, and they took that 3 times as much quote from the main results, which compares US prescription drugs to all countries, and it comes out to 287%. So that explains the 3 times as much. But what they do not account for is that there's also this little bucket down here, which is the unbranded generics. And for that, you can see with this yellow dotted line, that's the 100% mark. So you see the US falling short of that. So actually, generics are much cheaper in the US than they are elsewhere. So with that in mind, I think generics are something that is not quite accounted for in the way we do cost effectiveness analyses. Generics are just not really being factored in when we determine the new price for innovation. And one mental picture that I really like is one that comes from Peter Kolchinsky, who's written a book called The Great American Drug Deal, and he calls it the generic drug armamentarium. So he basically speaks about how maybe it's okay that in the short term we pay a higher price for new innovative therapies. We allow those drugs to come to the market, but then eventually, once those drugs hit the generic cliff, we'll just end up piling up this mountain of generic drugs and innovation that is just over time is getting bigger and bigger and bigger. So actually everyone's benefiting in the long run, but you still need to have that incentive at the very beginning to basically fuel the innovation of the global pharmaceutical industry. So that's a picture I really like. Maybe something that we're all more familiar with is a chart that looks something like this. So you've got your 3 traditional phases of the drug development lifestyle. You've got your early phases where everything is basically investment. You're in the red. You're dumping all your money, your hundreds of millions or billions of dollars into your clinical trial program, until eventually, just right around here, you launch your drug. You get your introduction phase, growth, maturity. Everything is great. Suddenly, you're getting lots of revenue. But then, eventually, you're hitting your decline phase. Maybe the first sort of competitors is on the horizon, and then eventually generic competition enters, and everything goes downhill from that. But again, this just speaks to the generic drug mountain that we've touched on before, because eventually everything hits this cliff, right? Eventually the generic competition just enters. So really all we're talking about is how big should this chunk be, this amount of revenue that the industry can generate while their new innovative therapies are mature and still early on in their life cycle to generate revenue. How big should this chunk be? And this is what we're currently debating, because with MFN, I'm not going to go into all of the details, but with MFN, this might change. How much money we're getting out of the US might change in the future. So I think it's important to all be aware of what are the things that MFN aims to address. And we're all familiar with this. So the goal is to stop foreign nations freeloading on American financed innovation. And that goes back to the very beginning, the 50% of global drug revenue coming from the US. So that's the first thing. And then lastly, also to enable direct-to-consumer sales to American patients at the most favored nation price. So those are the key things, and we've heard in the last week or so more details about how that might play out in the real world, which I'm not going to touch on. But it might change. How much money we get here might change. So I work in a UK and Ireland role, and there's been some rumors lately that things are looking like they might change soon with regards to the willingness to pay. So all of the things that are going on in the US, all this ruckus that is caused by Donald Trump has not left the UK unscarred. Large pharmaceutical companies have already sort of withdrawn major investment from the UK, and that maybe has triggered certain discussions between the UK government and its representatives and the US administration about making some deals in the background, potentially changing the willingness to pay threshold. Because the willingness to pay threshold, which again has been in place for over 25 years in the UK, has been unchanged. Nothing has been changed. And now they're proposing, or rumors are, they're proposing a 25% increase in the willingness to pay threshold, which would bring it up to this range, £25,000 to £37,500 per QALY. So the next question that then arises is that a good change? Does it actually make a difference? And, well, this is just for context again. We started 25 years ago. Nothing's changed since then. 20 to 30K. If you put that into real terms, it's actually a 47% decline. And, we've actually lost value per QALY that we're in real terms. You're adjusting for your, for inflation. That's something that's not been accounted for so far. And there's also this number which comes from the Green Book, which is the 70K per QALY number that they cite, which I've been told is not quite the right number to compare against, because the Green Book does like other stuff. It's sort of like a manual for other like policies, stuff like infrastructure projects that is being used in the UK. So it's not a one-to-one comparison, but at least it tells you that there's discrepancies and not quite the right adjustment between the number that's used by NICE, 20 to 30K, and 70K. So something really needs to change. But does it matter? So what we have here, this is from an IQVIA report, I believe, is the real net drug percentage as a part of healthcare. So if we take our overall healthcare budget, how much of that healthcare budget goes towards drugs? And you see that on average, it's 15%. Around 15% of all the money we spend on healthcare goes towards drugs. And you see certain variations across the countries that are included here in this analysis. And you've got two outliers. On the top end, you've got South Korea with about 20%. And then at the bottom end, you've got the UK with about 9%. So it's one thing if you say, great news, we're raising our willingness to pay. You all suddenly get better prices. That's great news. But if you're then saying, well, we're not really doing anything about this, we're still going to keep that at 9%, maybe it's not so much of a win as we make it out. And something that plays into this is are the clawback rates. So what are clawback rates? It's basically after the dust has settled, all the revenue has been made in a certain year. It's the amount of money that has been taken back by the government because they've got like certain spending limits, certain caps in place. And you can plot that across countries. You've got France, Italy, Germany, Spain, Belgium, Ireland here, roughly, all below 10%. And you've got one outlier, UK, 23.5%. So all that money, all that revenue generated by pharma, total sales is being clawed back. So they say, job well done, but actually I would like some money back. So clawback rates really outstanding here for the UK. And again, something closely connected to this is what's called the VPAG. I'm not going to bore you with all the details, but it basically sets growth caps for the rate of branded medicine. So that's all currently capped at 2%. And in contrast, we have the healthcare budget, the overall healthcare budget, so not just drugs, overall healthcare budget currently at 6.4%. So from this we see overall healthcare budget is rising way more than the budget for branded medicines is. So there's a disconnect there as well. And everything that's above the 2% basically gets the cap and gets clawed back. So with all this context, I was then wondering, what is the right level of reimbursement? How many drugs should receive reimbursement, right? And I'm trying to think about this on a spectrum. Like on the one end of things, we could say no to everything, or we could say yes to everything. So this is probably wrong. We probably shouldn't be saying yes to everything. There's always going to be a few drugs which don't really have that great efficacy, don't really add that much benefit to patients. That's just a reality we have to face. So that's probably not the right thing. And so I would argue is this. We probably want some drugs that are available on our market. So saying no to everything is also quite an extreme thought. You would think at least, because when I posted about this a while ago, some people were actually making an argument based on a recent paper from Narsi et al., which was sort of implying that that basically we should not reimburse drugs in the UK. That's sort of the takeaway from that paper. So what did that paper do? It was looking at positive NICE evaluations. So it had a set of 183 positive NICE recommendations over the last 20 years or so. And they've calculated the median QALY gain for those drugs that have received positive reimbursement. And the median QALY gain was about half a QALY for all those drugs. And they also reported the median ISA, which was just over 28K, 28.5. And in total, just over 3.75 million QALYs were generated across roughly 20 million patients. All of that benefit has cost, according to the estimation of the authors, has cost the NHS roughly £75 billion. Okay, so far you would think, well, great, patients have benefited from all those new drugs, right? So that's a good thing. But then they come to one central assumption, which is to say that the NHS can generate one QALY by spending £15,000 with existing treatments or services. So if you think about that, and you're convinced that this is true, £15,000 per QALY, and you're getting one QALY for that, then all of this, the 28.5K that you're spending for half a QALY on average, doesn't really add up. So what the authors say is that there's a net loss in population health impact of roughly 1.25 million QALYs. So basically saying, no, don't bother with the drugs. And that sort of sets the landscape and the atmosphere of the reimbursement environment in the UK currently at the moment, when you've got credited authors that are publishing stuff like that. So I wanted to then understand better, where does that 15K number actually come from? Who's saying that the NHS can produce one QALY at the cost of £15,000? And as far as I can tell, it all traces back to a paper from Claxton et al. From 2015, which don't actually report the number of 15K. They report it much closer to 12, just under £13,000 per QALY actually, but never mind that. They just used the 15K in that other paper. So what has Claxton et al. Done? How did they derive that number? So what they did is they looked at NHS spending data, gathered historical budget across several disease areas. They got that. They then did some econometric analysis where they calculated extra spending, mortality change, and life years gained for those historical budget and disease areas, converted that to QALYs, and estimated that threshold. So, and all of that, I've been told by one of my colleagues, has been presented at some sort of conference a long while ago. I think seemingly this was a very long project. I think it took them over 2 years or so to work on this, but this is the number they came up with. And I think their analysis has since this paper's been published, has been quite heavily criticized. I'm not going to go into the detail about why that was, but it's probably a piece of research that's worthwhile redoing just to check if this assumption actually holds true, and to redo that with a group of researchers that are probably unrelated to the original authors of this paper. Would be quite interesting to see how that turns out. Next, I also wanted to look at foreign investment as just like as another way of quantifying how the UK sort of like ranks up to its peer countries. And foreign investment, that it bounces around all the time, but you can take from this what you want. What I see is just a general decline over the years, starting out in 2017, where the UK was actually quite high up in the innovation rankings, on rank 2, just behind the US. But then eventually that has sort of like declined over time with a certain dip in one of the years. So again, fluctuates a lot, so just take that for what you will, but there's a sign that investors are drawing back and are not willing to spend as much money in the UK as they used to. So really this comes back to this point, like how many drugs should receive reimbursement? We've sort of agreed no to everything, that's probably not the right thing, yes to everything, not the right thing. So we end up somewhere here. And I'm very curious to hear actually like from you. So I'm going to ask you to just in a second throw some numbers at me. What do you think? Like what's the number of drugs that we should say yes to? If you had to give me a random number between 0 and 100%, what should it be? I take any guess. Just shout at me.
Without restrictions.
Let's not overcomplicate. Just yes to drugs that have undergone HTA, positive reimbursement, good drugs. How many should we say yes to?
70%.
Okay, we've got 70. Anyone going higher, lower? Question in the back? Or higher? Okay. Yeah, it's difficult, isn't it? Like, I don't quite know where we should end up and what's the right proportion. If you ask NICE, they currently lie at, I think, about 82, 83% of drugs that they say yes to. However, that is with the caveat of stating that not all appraisals which have been terminated are included in that number. So if you terminate an appraisal, that sort of gives you an idea. Probably the manufacturer was thinking, I don't really have the best chances of getting this drug through. I might just terminate the appraisal. There's not going to be a negative recommendation for my drug, but also those are not being counted into that 82% number, which makes it worthwhile for NICE because it gives good publicity to say, look, we're saying yes to 82%. Do you have a question on this, Neil?
Yeah,
or comment?
I think in that figure, we need to bear in mind that a lot of them are optimised, so they're only reimbursing for a limited percentage of the total potential population, which I think has been a particular issue in the UK, but we also see that challenge in some other markets in Europe. So yeah, even when we ask about reimbursement, it's whether that's going to be straightforward for the full label or more restricted.
Yeah, no, absolutely. But I think if you just like take the main headline, which is that's what the general public gets to see, they look at 82% and they may be thinking like, well, that's great, right? We basically say yes to everything. So I don't know if you guys, anyone in the room has been going through NICE appraisals, NICE submissions recently, and have sat in the chair where you actually, as part of the committee meeting, you sort of like the company sends representatives. They're there to answer questions. If you've gone through that experience, you're probably aware that it can be quite a stressful experience. It feels often like a tribunal almost. You're being criticized for everything. So I try to think basically in two ways, like how NICE appraisals should work and how NICE appraisals feel in practice from someone who's been going through a lot of these appraisals recently, and how do they feel to me? So sort of my subjective experience of this. So starting out with how should NICE appraisals work in practice? Well, they should be transparent. They should be evidence-based. They should be consistent in their application of the methods that you're using. They should apply consistent cost-effectiveness thresholds. There should not be as much variations. There should be timely access to innovative treatments, and they should be aiming to balance affordability with the clinical benefit. And they also should be supporting equitable healthcare across the NHS. That's sort of the perfect how NICE appraisals should work. But then if you look at the other side, here's how NICE appraisals actually feel in practice. And I think one thing that sticks out a lot is that word uncertainty. Uncertainty is a word that the NICE committees love. And I think, or my theory, why I think they love it, is because they use it as a tool to weaponize the NICE process to basically become an extension of a price negotiation process. Because whenever there's uncertainty, that uncertainty, your clinical trial isn't good enough, you haven't included the right number of patients, your patient population is slightly off, like all this uncertainty, maybe the methods that you use, your adjustment that you've done, it's all uncertainty, and that's always been thrown to the manufacturer. So by default, we are the ones who have to deal with that uncertainty, and that uncertainty is always being transferred to pricing, because 2 more minutes, better speed up then, which sort of leads to opaque and inconsistent decisions. So this is how it feels. I wanted to then see, am I the only one experiencing it like that? So I went out to LinkedIn, did a quick poll, checked earlier this morning, actually got quite a few more responses now, but I think the percentages are roughly the same. I was asking people, do you think the NICE appraisal process is fair and objective? And, at least half or so felt that yes, it is actually fair and objective. But then also just under 40% were saying, something's wrong with it. So they were saying only partly fair and objective. And I think with the latest number, this is actually up to 10% now. 10% were outright saying, no, it's not fair, it's not objective. And then some were unsure as well. And I think this number is particularly concerning because you might be thinking, only 10%. But if 10% of all people think that the system is fundamentally flawed, not fair, and unobjective, then something is certainly wrong. Also, I was asking the question, are we looking at the right thing? Because if you break down UK healthcare expenditure, 91% of all the costs are actually other costs, and only just under 10% are drug costs. Yet, this is where all the scrutiny is. We're always focusing about drug costs. So something's not quite right here as well. And if you break that down further, where do the other costs come from? So that 90%, what does that break down to? Well, it's mostly hospital cost. If you look at the US, 31%, EU, 37% of all cost are hospital cost. But then, why is it that when we look at the percentage of cost effectiveness analysis, what are they focusing on? Half of those cost effectiveness analyses are focusing on medicines, and 22% of those analyses are focusing on medical procedures. So again, the stuff that's happening here in the much larger cost block. Seems a bit weird to me. I'm going to skip over that in the absence of enough time. But yeah, I was also then looking at other countries because I wanted to get the scope a bit bigger, like what are other European countries doing. So this table is just like a cross-match of basically are different HTA bodies agreeing with one another. And what you can see is lots of red on this. So basically the takeaway is they all come to different conclusion, which is fair, because if you think about it, what's the point in having national HTA when, independent national HTA when they could not come to different conclusions? So there's maybe not too much to read into that. But it seems like there's a consistent pattern of we've got all these price control mechanisms in place in the EU, reference pricing, value-based pricing, managed entry agreements, centralized price negotiations. The list goes on, and part of that is obviously is available in the US as well. But Europe has been historically quite successful with depreciating and pushing down the price of pharmaceutical innovation. So solutions. Only got 1 or 2 more minutes to close this out. But what do I actually propose? So I may have come across as like very cynical and very negative about NICE, and but I just want to caution that by saying I think NICE is actually doing, for the large part, a good job. I think they're on the right track. They're very much advocating for the right methods and the right tools, but I think there's something that could be improved. And to be fair, a lot of that is also out of their hands with, the threshold thing, for example, is not set by NICE themselves. That comes through the UK government, which sort of like it all trickles down from them. So what are solutions for fair value? How can we build those solutions? I think they must be built on 3 pillars. So we've got our current models, that's pillar number 1, which foundation of everything that we do in market access and HTA. Value-based pricing, market-driven pricing, reference pricing, all those things still need to be in place. Then I think what already came across in the talk we've heard just before was risk-sharing agreements. I think that's something where we all need to do more. I think it's an under-leveraged tool. I think the processes that are in place to get these risk-sharing agreements in place are often too complex. And if we can simplify that, I think that would help to push pharma companies or incentivize them to manufacture or to have these agreements in place with the NHS. And then I think we also need to look at alternative models. Because this is sort of where the out-of-the-box thinking starts to happen. Because if you start looking at things like the Global Innovation Fund, for example, an idea where you'd think that, let's say, all countries globally would say this is how much money we're going to spend on pharmaceutical products. Let's say you adjust that by GDP or something like that. They all pay into this innovation fund, and then basically all drugs that come to the market would just get a slice of that innovation fund, sort of like globalizing access to new therapies. So that would sort of take away that discrepancy we have with like the US now complaining about, oh, we're the only ones really paying for pharmaceutical innovation. If you do something like that, Global Innovation Fund, you sort of make it fair across all countries in terms of their GDP, what they could be spending and contributing. So those are the solutions that I'm proposing. They're not revolutionary or anything. But then again, people have been thinking about this for 30 years and not really come up with great things so far. So the last thing I wanted to leave on with was this idea. And I partly took this because I think it's a very nice picture of, this nice oil painting of a harbor with this old sailing boat. But I just really wanted to use that as an opportunity to segue into a quote which I really like, which says that if you don't know which harbor you're sailing to, then no wind is favorable. And I think that's something that is very much applicable to HTA and market access in general, because we've got all these different things that we're trying to optimize for. We've got cost effectiveness, we've got our pricing, we've got the patient voice, we've got all these risk-sharing agreements, we've got now sustainability factors as well. So we've got all these multiple domains, and I think a lot of that was up earlier during one of the presentations with the ISPOR value flower. So we're maximizing in so many different domains, but if you're maximizing for everything, then really what you're doing is you're maximizing for nothing. And I think really it just comes down to, what should we optimize for? Are we optimizing for outcomes? Are we optimizing for affordability? And I think especially with that affordability bracket, it's something that you should be more honest about, because it's totally okay to be in this affordability bracket if you're in an economy that maybe your economy is declining. Maybe you just can't afford as much healthcare, and that's very tough to sell to a general public, of course, but it's just the truth. So I think that's the key balance: outcomes, affordability, somewhere between the two, and obviously ensuring that ultimately patients get the best value for their money through their respective healthcare systems. Thank you.